أهلا بيكم. Today we're going to conclude the neck by studying the suboccipital triangle, and we will start with the head proper by studying the parotid gland. So let's start. The part of the back region is the back of the neck, and the muscles of the back you will study later that they are divided into groups, superficial and deep groups. Today we're going to study a special part of the deep groups, deep group of muscles of the back at the neck region, at the back of the neck, right beneath the skull. It's called the suboccipital triangle, composed of muscles that connect. We will work on the atlas and the axis, the first C1 and C2 vertebrae. The muscles, they either connect the vertebra with each other, like this one, for example. See, from the spine of C2 to the transverse process of C1. To be oriented, this is a longitudinal section through the head and neck. This is the tongue, this is anterior, this is the oral cavity, and this is posterior on the left side. See that oriented now? For example, this muscle, this connects vertebrae with each other. These muscles connect vertebrae to the skull. See, like this one and this one and this one. So these are together called the suboccipital triangle muscles. The boundaries of the triangle: lateral boundary, which is the superior oblique or the obliquus capitis superioris muscle. It takes from the transverse process of the atlas to area between the superior and inferior nuchal lines on the back of the skull. The floor or inferior boundary, of the triangle is the inferior oblique or the obliquus capitis inferioris. As you can see, it's attached to, it takes from the spine of the axis to the transverse process of the atlas. So it connects vertebrae together. And on the medial side, the medial border is formed by two muscles. As you can see here, this is the big one. It's called the rectus capitis posterior major. And besides it, near the midline, is the rectus capitis posterior minor. As you can see, the rectus capitis posterior major takes from the spine of the atlas to an area below the inferior nuchal line, and the rectus capitis posterior minor takes from the back of the atlas, the posterior tubercle, to the area of the inferior nuchal line and below it. So this is the lateral boundary, this is the inferior boundary, this is the medial boundary. The floor, as you can see it here, the floor is by the posterior arch of the atlas, with the structures on top of the posterior part. We will see them now. Okay, oriented now? It's easy. Three borders, and the floor by the atlas, by the posterior arch of the atlas. Okay. Now in this drawing, this specimen, as you can see, you must dig deep to reach for the suboccipital triangle. First, on top, of course, there will be skin and fascia. And then you will get to the splenius capitis muscle, the semispinalis capitis muscles. They cover the suboccipital triangle. When they are reflected, the triangle is exposed now. See, this is the inferior oblique, this is the superior oblique, and this is the rectus capitis posterior major and minor besides it. And in the floor, you can see the back posterior arch of the atlas. Now the contents of the triangle: a major artery and a nerve and veins. The major artery is the vertebral artery. This is called the third part of the vertebral. The first part was before it enters the vertebrae. The second part was while in the vertebrae, in the transverse foramina of the vertebrae. The third part, well, it curves medial, posteromedial, and then will go up through the foramen magnum inside the skull. This is the third part of the vertebral artery. Now, in this drawing, there is a mistake, and trust me, you will find mistakes in atlases, like this one. See, this is the dorsal ramus of C1, which supplies only muscles. It's short and does not supply skin. Actually, it supplies the muscles of the suboccipital triangle. This one. It should come out between the artery and the bone, means below the vertebral artery, above the posterior arch of atlas, or between two. Whatever they bring you the form in the exam, it should be beneath the third part of the artery, not above it. This is a mistake. So remember, you have the third part of the artery sandwiching the posterior ramus of C1 between it and the posterior arch of the atlas. Now, what else you can see in this region? I forgot to say in the roof, the one we excised out, like the splenius and semispinalis skin and fascia, the nerves will find cutaneous nerves like branches of this nerve. This is the great occipital or dorsal ramus of C2. This is important. C2, dorsal ramus, the great occipital. Dorsal ramus of C3, the third occipital, also supply the area. What else you will find in the area? Now, if we bring this muscle back, you will see the branches of the occipital artery. Remember the occipital artery, it's branch of the, exactly, the external carotid artery. It's a branch of the external carotid artery above the posterior belly, actually deep to the posterior belly of digastric, and then the posterior auricular, which is anterior to it, it's away from the triangle. So the occipital is the one that supplies the roof of the triangle. Okay, so again, to recap, skin, fascia, nerves like the branches of great occipital, third occipital, vessels like the occipital vessels supplying the area. Then the floor is by the posterior arch of the atlas with the dorsal ramus of C1 on it, and then the third part of the vertebral artery, and some veins, of course, draining the area. And the boundaries of the triangle are the laterally is the superior oblique, medially is the rectus capitis major and minor, and inferior border is the inferior oblique. It's a very simple topic, and it can easily come in an essay and many questions in multiple choice. You will find it there. Okay, I hope you got the idea about the suboccipital triangle. Don't forget the sensory supply we talked about, the C2 and C3, and that C1 dorsal ramus does not supply skin, it supplies only the muscles in the area. This covers it all. Okay, now I can say that we are done with the neck. It's over with the neck. Now everything will be in the head proper. Starting with today's topic, which is the parotid gland. I think we talked about the parotid gland before. We said it's one of the, it's the largest of the three pairs of salivary glands, the parotid, submandibular, sublingual. And remember, we said that the glands were classified according to the type of secretion they produce. Is it watery secretion? Is it mucus secretion? Or a mixed secretion? Remember, when we studied the submandibular gland, it was classified as mixed. When I showed you a picture of the histological structure, you couldn't identify lots of blue and lots of vacuoles indicating mucus. But with the parotid You can't mistake it because it's all scattered blue. It secretes a watery saliva rich in enzymes. Now, we said it's the largest of the serous type. See, it's like a piece of dough impacted in the area between the posterior margin of the mandible and the ear and skull. See, and sternomastoid. Yeah, as if you brought this piece of dough and you impacted it. You impacted it there. This is the parotid gland. It extends upwards in a concave surface facing the external acoustic meatus, the cartilaginous part of the external ear, and below the ear. Extends backwards, see? It covers part of the sternocleidomastoid muscle, right? Extends down till the apex. The apex is at the level of inferior margin of the mandible and is on top of the digastric. We will mention that now with the medial relations. Anteriorly, see, this is the anterior border of the gland. It overlaps the masseter muscle. So it overlaps a muscle posteriorly, which is the sternomastoid, overlaps a muscle anteriorly, which is the masseter muscle. Okay? And you may find some accessory parts like these parts. See? These small parts. These are called accessory parotid gland. And they belong, of course, to the parotid, but developed around the duct of the gland, between the duct and the zygomatic arch. High above, it extends to the level of the zygomatic arch. So, again, zygomatic arch, the ear, the external ear, and back to the sternocleidomastoid, apex downwards, anterior on the masseter, and back to the zygomatic arch. Okay? It's a big gland. By the way, I told you it's a piece of dough. So you expect more of this dough inside. Inside, there is a deep part of the gland between the medial pterygoid, the one opposite the masseter. See the masseter from the outside? On the opposite side, on the medial side, there is a medial pterygoid, and there is a space between the medial pterygoid and ramus of mandible that has the deep part of the gland in it. Okay? Please don't forget this information. Okay. We talked about the accessory parotid. Some books you may find another description of the gland, dividing it into processes. Like, for example, this process called the glenoid process. Like all this surface, this is the facial process. Like the accessory parts, the accessory process. Like the deep part between the medial pterygoid and the ramus of mandible, called the pterygoid process. So you may find this description that it is thrown into processes. A glenoid process related to the neck of mandible and the TM joint above. Facial process, which is almost all the gland you can see here. Accessory process that around the duct, and deep process that's between the medial pterygoid and the ramus of mandible. Don't forget, anteriorly it reaches the masseter with the facial vein on it. The gland may be big to cover part of the facial vein. It may come underneath the anterior border of the gland. Okay? Okay. Now, the parotid duct. Of course, ductules collect from all over the gland and form the parotid. Usually it's a single parotid duct that emerges from the anterior border, see? Midway between of the distance between the zygomatic arch and line with the angle of the mouth, midway. It passes anterior, of course, it will find itself on the masseter. And as I told you, you may find some parotid tissue around it, accessory parotid gland. Now, it travels over the masseter, and then pierces the fat and fascia in the cheek and goes deep to pierce the buccinator muscle. Now, doctors, please, in all sources, you will find out that it pierces the buccinator and opens opposite the upper, in the vestibule of the mouth, opposite the upper second molar tooth. This is well known that the duct will open in the vestibule of the mouth, opposite the upper second molar tooth. Now, in some British exams, for the membership, MRCS for example, you get this information in another way. Look, doctors, the duct pierces the buccinator level with the third molar and then runs forwards inside the muscle fibers, still inside the muscle. This is called the intramural part, valve-like action. Then it opens opposite the upper second molar tooth. So actually the duct, yes, it opens opposite the upper second molar tooth, but I got this question, trust me. Where did it pierce the buccinator? It pierced the buccinator opposite the upper third molar because it went forward for 1 molar distance and then pierced the buccal mucosa. Got that? Please. It pierced the buccinator opposite the upper third molar, traveled for a while in an intramural part for a valve-like action, and then opened in the vestibule of mouth opposite the upper second molar. Now, if you want the surface anatomy of that, and this is important, draw a line from a point midway between the ala of nose and the angle of mouth here. This is a point. The other point is at the tragus of the ear, this anterior protrusion, tragus. Tragus to a point midway between the angle of mouth and ala. The middle third of this line is the parotid duct. So it's the middle third of a line drawn between the tragus and a point midway between the angle of mouth and the ala of nose. This surface anatomy is very important as well. Please do not forget this. Now about the duct too, we said it may be surrounded by accessory parotid. The transverse facial vessels are above it, between it and the zygomatic arch. So above it are the transverse facial vessels, and I got this question too, multiple choice question. Above it, the transverse facial vessels branch of the superficial temporal artery and tributary of the superficial temporal vein. They travel above the duct of the parotid. Okay, coming from the inside, of course, because the beginning of the superficial temporal artery is actually inside the substance of parotid, and we will talk about this. Okay, relations of the parotid. The way I want you to remember this is to divide the media relations into posterior part, anterior part, and middle part. And then the superficial relations, okay, there are no problem with them. Superficial relations are skin and fascia, of course, right? And what else? We will go inside the gland and we will find structures inside. So these are not superficial. They are in the substance of the gland. The medial relations, anteromedial relations, posteromedial relations, and medial relations proper in the middle. Anteromedial is the masseter with the facial vein on top, right? This is anteromedial. Posteromedial is the sternomastoid, and if you remove the sternomastoid, you will find the posterior biliodigastric and the stylohyoid muscle descending, right? So this is medial, posteromedial to the parotid gland, right? Okay, Don't forget the deep part that extends between the medial pterygoid and the ramus of mandible. Medial, in the middle, I mean, is the styloid apparatus, which is the styloid process with the 3 muscles and 2 ligaments attached. Remember the styloid process? The styloglossus that takes from the front of the styloid process, front down. The stylohyoid muscle that takes high up from the back of the styloid and descends to the lesser cornea of the hyoid. And the stylopharyngeus that takes high up on the medial surface and descends to the pharynx, right? Okay? Now remember that the stylohyoid muscle, deep to it was the external carotid artery, right? And remember that the stylopharyngeus, like we said before, and styloglossus are between the external carotid and internal carotid, which is the deepest structure here. So medial to the gland, you will find the stylohyoid, posterior belly of the digastric, then the external carotid, then the 2 muscles, the styloglossus and stylopharyngeus, then the internal carotid artery wrapped with the internal jugular vein in the carotid sheath. Now you're oriented. Can I add extra structures? Yes. With the stylopharyngeus, you can add the glossopharyngeal nerve. You can add the pharyngeal branch of vagus. All between the external carotid, which is medial to the stylohyoid, means deep to the stylohyoid, but lateral to these 2 muscles, and the internal carotid, which is deep inside. Got it? It's easy. This is the styloid apparatus, which is actually medial relation to the parotid gland. Now we'll lift up with the structures inside the parotid gland. Passing through the parotid gland, nerve, vein, artery. And this is the arrangement from superficial to deep. Nerve is the most superficial. This is extremely important. The nerve is the most superficial, then comes the vein, then comes the artery, which is the deepest structure, okay? The nerve is the facial nerve. The facial nerve, as it comes out from the skull, from the stylomastoid foramen, it gives off the posterior auricular branch, gives off branch to stylohyoid and posterior belly of digastric, okay? And then enters the gland, as you can see. Inside the gland, it divides into 5 major divisions. The superior division, you can call the temporal. This is the zygomatic division for the cheek. Buccal division for the cheek. Marginal mandibular division, parallel to the inferior margin of the mandible. And the cervical branch below in the roof of the submandibular region. Remember, we've mentioned this branch, the cervical branch of facial, that is in the roof of the submandibular gland. So that's why during surgery, do your incision lower down, not close to the margin of mandible. You will cut these branches, right? So you have temporal, zygomatic, buccal, marginal mandibular, and cervical for platysma. It's like putting, for example, if you want to know the branches of the right side of face, put the palm of your hand on your right side, thumb facing, pointing upwards, and the rest of the fingers pointing forwards anteriorly. This will be the branches of the facial nerve. The facial nerve, actually, it interconnects inside the substance of the parotid. It connects, the branches connect, makes a network, and it's variable. You may find 2 major trunks, then they give the branches, or each branch is coming out individually. You will find many variations, but at the end, the branches come out and go to their target areas as 5 major branches, as we said. Now, the plane through which the facial nerve travels in the parotid gland, this is the the mark for the surgeon in the parotectomy. If you are doing parotectomy, you will be worried about hurting or injuring this nerve. So this will be your limit. It divides surgically the gland into superficial and deep parts. And of course, part of the superficial lobe of the gland is deep as well because of the facial nerve. You got it? So this is surgical landmark, the facial plane. Not anatomical, it's surgical landmark. Okay, what else? Deep to the nerve, I said we'll find the retromandibular vein. Now remember, we will study with the face and scalp the superficial temporal vein coming down in front of the ear. It will meet the maxillary vein that's coming out of the pterygoid venous plexus to form a big vein equivalent of the external carotid artery. It's called the retromandibular vein. Okay? It's called the retromandibular vein. The retromandibular vein will go down inside the substance of the gland, and then below it divides into anterior division and posterior division. The posterior division of the retromandibular vein will meet the posterior auricular vein to form the external jugular vein, and this we discussed at the very beginning of the classes with the posterior triangle of the neck. The posterior division of retromandibular with the posterior auricular form the external jugular vein, while the anterior division of retromandibular goes with the facial vein to form the common facial vein on its way to the internal jugular vein. Okay? So the anterior division with the facial to form common facial, posterior division with the posterior auricular to form the external jugular vein. This is the retromandibular vein, which is the middle structure in the substance of the parotid gland. And the deepest structure, of course, you'll find is the external carotid, giving away its last branches, the posterior auricular branch. It gives it inside the parotid gland and then divides into its terminal branches, the superficial temporal and maxillary to the front and medial. Remember this? This happens inside the parotid gland. So don't forget, if you want to talk about relations of the gland, don't forget the special arrangement of the medial side, posteromedial, anteromedial, and medial. And don't forget the structures inside the gland, actually, in the substance of the gland. It's very important. And their arrangement, that superficial is the nerve, then comes the vein, which is logic, superficial to the artery. Okay? This is about the structures inside the parotid gland. Now, the arterial supply for the gland comes from the external carotid, of course. It's inside the gland, so it will supply the gland. No problems about that. Parotid branches. And the veins follow the arteries, as usual. Now, the innervation. Don't mistake the innervation as only parasympathetic. No. We have sensory impulses coming from the gland. From the gland and its capsule. Sensory, pain, touch, temperature, general somatic afferents. These are carried from the area of the gland. And there is the supply, the parasympathetic supply, which will ignite the gland, which will make the gland work. The general visceral efferent or general visceral motor branch that will motorize the gland, as you know, stimulate secretion. Now, sensory innervation is taken up by the auriculotemporal nerve. This is the auriculotemporal nerve. It's a branch of the mandibular nerve. And the great auricular nerve. Remember the great auricular? When we studied the cervical plexus with the posterior triangle, we said that the great auricular goes upwards towards the parotid gland, supplies the capsule there, and supplies the skin over the parotid. And we said never forget that the angle of the mandible, the skin over the angle of the mandible, skin over the parotid is supplied by cervical nerves, by C2, not by cranial nerves. Remember this? This is a very important point. So the auriculotemporal and great auricular for the sensations, and for the general visceral efferent. Now this is a long story that we will encounter again when we get to study cranial nerves in the head. A branch from the glossopharyngeal, which is the ninth, this is not the glossopharyngeal, the glossopharyngeal, ninth cranial nerve. After it goes out from the jugular foramen, right after it goes out or at the jugular foramen, it gives a branch that will go back inside the skull but with a different foramen of its own. It's called the tympanic branch. This tympanic branch will appear in the middle ear to form what's so-called the tympanic plexus, and from the tympanic plexus a nerve will arise and emerge from the bone of the middle ear called the lesser petrosal or small petrosal. See this one. It will go anterior till the foramen ovale and the skull. It goes down through the foramen ovale with the mandibular nerve to synapse in a ganglion called the otic ganglion. Now again, there was a tympanic branch from the glossopharyngeal to the tympanic plexus inside the middle ear, and from it there is a lesser petrosal inside the cranial cavity, travels forwards till it finds the foramen ovale where the mandibular nerve goes down. It will go down with it and synapse with a ganglion immediately below the foramen ovale. It's called the otic ganglion. It's at the medial side of the nerve. See, here we are looking from the medial side. So the otic ganglion is apparent here, as you can see. This is the otic ganglion. Now what happens? The lesser petrosal is preganglionic parasympathetic fibers. It will synapse, so you expect postganglionic parasympathetic fibers that will come out of the otic ganglion, finds a way to reach the gland, which is through the auriculotemporal nerve, will take it back to the gland. So the pathway is like this: tympanic branch, forwards lesser petrosal, downwards otic ganglion, backwards again with the auriculotemporal nerve to supply the gland with parasympathetic secretomotor supply, which will stimulate the secretions for the gland. Okay? Got it? Great. So it's originally from the glossopharyngeal, but reached it through a branch of the trigeminal, which is the mandibular branch, the auriculotemporal branch of the mandibular of trigeminal. Okay? It's easy. Don't get confused with the submandibular and sublingual. We said their ganglia is the submandibular ganglion, the one that delivered the parasympathetic supply. Remember, the lingual nerve via a nerve that joined the lingual nerve. It's called the chorda tympani, that came out from the facial. So remember this, that the major glands, the parotid is supplied by the glossopharyngeal, while the submandibular and sublingual glands are supplied by the facial, right? And all glands above the oral fissure, actually in the palate and in the soft palate back there in the pharynx, are supplied by the facial too, but not through the chorda tympani, through the great petrosal nerve. Now you know the map. Glands high up by great petrosal of facial, glands lower down by chorda tympani of facial, gland at the side by the glossopharyngeal nerve. This is the plan for the parasympathetic supply of the salivary glands. Now, there's a very interesting syndrome here called the Fraze syndrome. In patients who undergo operations on the parotid region, of course, you will excise tissue and denervate structures. From the structures denervated will be sweat glands and some blood vessels, right? Because you're removing tissue. Now, after the operation, post-operative, the nerves, the parasympathetic supply for the gland will start to regenerate. Now, when it regenerates, it will supply extra structures like the sweat glands that were denervated before. So this is odd. Why? So this patient, whenever he thinks about food, starts to produce saliva, for example, or whenever he's chewing or eating something, this area of skin over the excised gland, excised part, will get hot with itching and burning sensation. It's called neuralgia, okay, and will get sweating, will be covered by sweat, and it will be flushing because of the dilated blood vessels. Why? Because of the mistake that happens during the regeneration of the parasympathetic fibers that were excised before, cut before in an operation. Okay, I hope this gave you an idea, good idea about the gland. I hope we covered all the questions, possible questions about this gland. I don't think you will find any problem in answering any MCQ about this gland anymore. Okay, so we concluded the neck. We started with the head. I wish you all the best and thank you all for watching.